first and foremost, I'll start with a little bit of a bragging right. You see that, the title of the entire conference. I mean, I don't claim I'm the first person who said that. I don't claim I'm the only person who said that, but I have repeatedly said for any diabetes conference, especially DiaCareCon, that it should be called DiaCare and Obesity Con, right? If Dr. Unni sir is somewhere here listening, well, IDS should be called International Diabetes and Obesity Symposium starting next year, and RSSD at some point of time should be called RSSDIO, right, or RSSDOI, right? Obesity, trust me, right? Well, whether this is going to be DiaObecon, Obecon in this year, in 10 years, it is going to be Obesicon for sure, right? Diabetes will be a fringe player in management of the entire spectrum. Why is this so? For one simple reason is that you are treating something upstream. You are treating the actual problem, not the symptom of the problem, right? Type 2 diabetes is quintessential a disease of obesity, right? It is a disease of abnormal fat. It's a disease of adiposity. And if you treat adiposity, you are treating the diabetes. If you treat adiposity, you are treating the heart failure with preserved ejection fraction. If you are treating the adiposity, you are treating PCOS, right? You are treating the root cause of these diseases. So with this, this is the standard disclosure. Let's understand the most powerful weapon that we have for countering obesity in 2025, and that's Tirzepatide, right? Now, it's always like this, that the first one out of the door gets shot, right? You take the journey of GLP-1, you had exenatide which came first. Nobody really remembers exenatide, right? It's liraglutide which took all the limelight. And then in terms of weekly GLPs, you had dulaglutide which came first, which nobody really talks much about dulaglutide except as an active comparator, right? You have Tirzepatide which takes the, limelight. So it's always been, continuous progressive evaluation, continuous progressive improvement. But as of now, the best agent that we have is Tirzepatide. And why is Tirzepatide the best amongst all the obesity agents available today? Is because of these reasons, right? So if you see, most of the other agents that we have in the market, they are GLP-1 receptor agonists. They are good, right? GLP-1 has a very important role to play. But the biggest problem with GLP-1 is that when you try to increase the dose of GLP-1, at some point of time, the side effects start catching up. And the biggest hurdle to GLP-1 therapy is the GI side effect, right? The bloating, the nausea. You keep increasing the dose of these agents, you keep increasing the nausea and bloating. And it is one of the primary mechanisms by which it acts. So there is very little you can do to counter that. The good thing about a combination of GLP and GIP is this. The GIP, which comes along with GLP, actually reduces the upper GI symptoms. It actually reduces the nausea and vomiting. And if you use it in the diabetes spectrum, and we'll be discussing this later, if you use this in the diabetes spectrum, GIP is an agent which actually reduces risk of hypoglycemia. So if you see any clinical trial where Tirzepatide has been used, you will see that the risk of hypoglycemia is very little, risk of upper GI symptoms are very less. In fact, they are lesser when you compare it head to head with semaglutide. So that is the biggest advantage which you have with Tirzepatide, that you get a benefit with lesser commonly affected side effect. The other very interesting thing, and which I realized when I started using GLP, and which all of you would, when you started using Tirzepatide, and which all of you will realize when you start using it yourself, this is literally an agent which melts away the fat, right? I've seen this, you see, try checking out PubMed and a lot of the research articles where they've looked at NFLD, MASLD pictures, right? They've seen before and after pictures of patients where they've taken, MRIs of the liver. And literally you have liver studded with fat, and post Tirzepatide, you have literally the liver free of fat, right? The most visible form of fat is the fat in the liver. And if this is what is happening to the fat in the liver, imagine what is happening to the fat elsewhere, right? Literally you have melting away of the fat. And if you see from a scientific perspective more efficiently, what you realize is that the adipocytes have GIP receptors, and you have this GIP acting on these adipocytes, literally melting away the fat, right? So you have, these are the PK/PD profile, It has a half-life of about 5 days, right? And it tends to, remember, it's a GLP, GIP combination, but it's predominantly a GIP agonist more than GLP, if you see. So that is the standard, PK/PD of this agent, right? Now, let's then look at how tirzepatide really impacts the diabetes management as well as the obesity management, right? So let's see from that perspective. Now, the first thing I'd like to tell you is that we are in an era where, when you're treating obesity, and obesity has always been a little bit untouchable in terms of management, because when you're treating patients with obesity, you're treating a population which is generally considered to be healthy. And hence, as a company, you want a drug which does not have major side effects, does not have any long-term or short-term side effects, because there have been drugs in the past which have come and gone, right? We all know about, rimonabant, we all know about lorcaserin. Lorcaserin, there are patients who said, "Sahib, black market ma lorcaserin lao, but I want that drug," right? But for whatever reasons, it got out, right? Hence, when these companies went to an expansion of labels beyond diabetes, they're looking at a very wide safety net, right? Eli Lilly, an American company, doesn't want to be sued by Americans, for sure. They know about the legal structure in the United States. One bad case and they'll have, taught things, they'll have a big barrage of lawyers after them, right? They don't want that. So what they've done, and what semaglutide has also done, is to have large data set, right? Unproven, unfallible data, right? As you can see here, more than 6,000 participants have acted in randomized clinical trial. Massive number, massive number. And this was just for diabetes. If you see from obesity perspective, more than, again, 6,000 patients who have participated in the obesity trials. So in terms of RCT alone, there have been more than 12,000 patients who have participated in randomized clinical trials, unprecedented in history of clinical trials, right? Tell me one more clinical trial where you had such a massive number of patients, and in such a massive number of patients, safety has been proven, right? So if your patient's talk after reading some nonsense on social media comes and talks to you about side effects of the drug, I'll tell you there are more side effects of the water that you drink than tirzepatide. The very reason is that tirzepatide has been tested in 12,000 patients with the, the side effect profile, which is now very well documented, very well known. Whereas the water in Ahmedabad, you don't know, right? There is no clinical trial. So I'm not saying water is, this is safer than water, but I'm saying is that, you see the difference, right? Again, there are dual indications. So tirzepatide in India has been approved both for type 2 diabetes as well as for obesity. You can clearly see, right? It has got a DCGI approval for both. And there are clear indications for obesity management. If you have any patient with BMI more than 30, you give this. If you have a patient with BMI more than 27, with any end organ results, you will give this agent as well. Right. Now, let's then first focus on obesity management, right? And we already told you there are clear indications of where you'll use this agent. So any patient with BMI more than 30, you'll use it. With more than 27, you need to have an additional factor, right? For example, you could have diabetes, you could have a patient with obstructive sleep apnea or something else. But let's then first focus on obesity. When I tell you this number, right, it's a staggering number, right? Across clinical trials, tirzepatide has shown close to more than 20% reduction of the weight. When I talk about 20% reduction, just imagine a 100 kg person, right, loses 20%, 20 kgs, he'll be 80 kgs, right? You can literally imagine the change in the body structure he'll have, right? Just visible change will be profound. And if you see under the hood, the risk of almost every disease which is attributed to cardiometabolic disease will significantly reduce when the patient reaches 20% weight loss. There is no doubt about it, right? So this number is unprecedented, and 1/3 of the participants lost more than 20% weight across the board, across clinical trials. So this is not a small number, and this is no joke. And like I said, when you have the components of the cardiometabolic risk reducing, right, you also have the other parameters which reduce. So apart from the diabetes, apart from the weight, you also had reduction of systolic blood pressure close to 10 millimeter Hg, 7 to 8 millimeter Hg, right? I mean, this is what you are reaching antihypertensive levels, right? You have reduction of triglycerides, which is quite significant. You have reduction of LDL cholesterol, which is also significant. Again, let me tell you, and again predict the future, both tirzepatide and semaglutide will be the drugs of choice as anti-atherosclerotic agent in the future, right? I said this about SGLT2 again, I'll say again bragging rights. I said this about SGLT2 before SGLT2 started being used by cardiologists. I said this is the drug which is going to be used for heart failure. This is the first line drug which is used for heart failure, right? Well, people took it lightly, right? But right now, if you see any guideline, I just came from a conference about heart failure. The only thing they talked about was SGLT2. It's all SGLT2, right? Same thing will happen with Tirzepatide and semaglutide. In 5 or 10 years, you will hear less from me and more from cardiologists about Tirzepatide and semaglutide, right? These are the quintessential atherosclerotic agents which are going to be used, right? They are, if you see data, you have far more effective data than statins and aspirins and all these things, right? You are actually again here also treating the root cause of the problem, right? Talking about adverse effects, right? Generally, what we have experienced, I'm telling you from experiential perspective, the most common side effect is lower GI symptoms. Lower GI side effects are the most common side effects that you see the patient experiencing. Constipation and some cases diarrhea, right? So when the patient has diarrhea, what we typically do is we withhold the drug for a short period of time, give them some probiotics and then re-challenge, right? And it often doesn't happen again. But when the patient has constipation, a lot of the time, these patients, there is a reduction of appetite, and along with that, they also start reducing their water intake, right? So whenever you have a patient complaining about constipation after starting Tirzepatide, just assess their water intake and encourage them to take more fluids. It's a very common phenomena. It has been well documented in clinical trials also, right? So it's a very, very common issue. Let's then compare it with the drug which you should compare. Actually, I'll say this is a very unfair comparison because you are comparing a dual agonist with a single agonist. But having said that, these are the two champions which we have in today's era, Tirzepatide and semaglutide, right? What are the benefits? Now, I think, head on head, if you talk about weight loss, there is no competition, right? Tirzepatide hands on because there's a head-to-head Surpass 4 trial which has clearly shown that Tirzepatide has benefit in terms of weight reduction, right? And if weight is the only thing which your patients bother about, to be honest, that is the only thing which the patients understand, right? There is no doubt the bigger bang for buck, right, you will get is with Tirzepatide for sure, right? Then of course, if you talk about, the other things like waist circumference reduction and other things also, you will find benefit. And again, the other thing which I said, that which is from your perspective. Now again, I'll tell you, Tirzepatide, right? We have lots of patients on Tirzepatide right now, hundreds maybe. What I'll say is that this is a drug which is easily acceptable by your patient, right? There is not a single patient who has come and complained about Tirzepatide, right? We had issues with semaglutides, liraglutides, even the generic liraglutide that we use, right? There will be some patients who come and complain about GI side effects. They don't want the dose to be escalated, right? Tirzepatide patients come and tell you, "Ke sahib, 5 milligram kya re chalu karshu? 7.5 milligram kya re chalu karshu?" Patients themselves coming and telling you that I want dose escalation because I am tolerating the dose very easily, right? Amazing tolerance of this agent, right? Apart from, like I said, constipation for patients who do not take water intake adequately. The other things are generally very, very less. And diabetes management, I'll just summarize in a couple of slides. When you talk about diabetes management, I'm sure, most of the people who have used Tirzepatide would agree with me, right? When we are talking about a completely different thing about obesity, as of now in India, right, the most effective anti-diabetic drug is also Tirzepatide. There is no comparison, right? There are patients of mine who for years together were on multiple drugs and their diabetes control was not even close, right? Every time they'll come with HbA1c of more than 10. We started them on Tirzepatide, we have reduced their insulin doses, we have reduced their medications, they are now hovering around 7% and very happy, right? So there is no better anti-diabetic drug. It's unfortunate that diabetes is not being, really focused on. I think it's the best anti-diabetic, right? To Eli Lilly people who are listening, right? No, hands down, right? So, again, if you, don't take my word for it, just see the data, right? Close to 2 to 2.5% HbA1c reduction. Tell me which other anti-diabetic drug can do this very easily along with the other benefits, right? So very, very few. Okay. Along with that, of course, like I said, hypoglycemia and GIP has a dual mechanism. So when you have hypoglycemia, GIP actually encourages the release of glucagon. So, and this you have experience with, we have been using DPP4 for a long time. Remember, DPP4 inhibitor inhibits the breakdown of both GLP and GIP. So it's actually a dual agonist before you are using dual agonist, right? And we know with DPP4 that the risk of hypoglycemia is actually reduced. We have seen that with multiple CGM studies. Same thing you see with Tirzepatide. You actually have in your diabetic patients lower risk of hypoglycemia with this agent, right? So this is the thing. I just summarize here. I'll take a couple of take-home messages from my side. The first and the most important thing is adiposity is the disease which you now need to focus on, right? DiaCare-Con needs to be always Dia-Obesity-Con, right? Or in future, Obesity-Con with a diabetes having one symposium of diabetes in one hall, that's enough, right? Rest should be obesity. Adiposity is the disease which we need to treat. If you're treating that, you're treating the root cause of multiple pathological processes. Secondly, the most powerful anti-obesity drug available in the Indian market and anti-diabetic drug available in the Indian market is Tirzepatide, there's no doubt about it. Very few side effects. The only thing you have to really bother about is lower GI side effects. But patients, there is very little discontinuation because of lower GI side effects. Very few. Trust me on this, right? And finally, in terms of the guideline recommendation, it is recommended both for type 2 diabetes as well as for obesity, right? For type 2 diabetes, standard indication but for obesity, when you have a BMI more than 30 or BMI more than 27 with an additional risk factor like a diabetes, obstructive sleep apnea, and so on, right? With this, I end. Thank you for a patient listening, and thank you to Banshi sir for having me for this conference.